So I have no financial disclosures, but I am in the leadership of several organizations. I just want to make it clear that I'm speaking, and these are my opinions and not for any of the organizations in which I hold a leadership position. You know, when we think about surveillance endoscopy, both before and after sleeve, and I've been doing sleeves for a long time, you know, this is a concept that we've really started to come to a national and international discussion somewhere around 2016, 2017. But I think it was this paper by the group out of Rome that I think really brought it to really prominent discussions. Because when they published this paper in 2017, they presented us with a series of patients, 162 patients, and they described the fact that they had done GERD scoring and EGDs preoperatively in all 162 patients. They described their surgical technique. But what they had done that not many groups before them had done is at about 58 months, they got 110 patients to consent to having a follow-up EGD, whether they were symptomatic or asymptomatic. Now, there is some selection bias because they didn't get EGDs in everyone, and I'm sure there were some asymptomatic patients that probably did not consent to the EGD. But 68% of the patients did report GERD symptoms, and 57% of them were using a PPI. And what they noted on the EGDs of these 110 patients was an upward migration of the Z line in 73% of the patients, which was a significant increase from their preoperative scopes. Bile reflux in almost 75% of the patients that they scoped. But what really, I think, shocked a lot of us when we first read this paper was that 68% of the patients had some degree of esophagitis. And this is what really opened our eyes. 19% of the patients had Barrett's esophagitis. And but we didn't have a lot of details about the Barrett's in that particular study. But in the same year, a group out of Chile posted another very impressive study because they actually had 10-year follow-up with 93% of their patients consenting to an EGD 10 years out. And in fact, they looked at 104 consecutive patients from early in their series that had preoperative EGDs, and then one at 1 month, 1 to 2 years out, and 10 years out. And like I said, they actually had 97 or 93% of their patients get that 10-year scope. They divided them into two groups, patients who reflux and patients who did not reflux. And what they found is from the people who had no reflux pre-op, 58% of them developed reflux post-op, and on scope they developed esophagitis, hiatal hernias, and dilated funduses. The refluxers, on the other hand, only about 13% of them had resolution of their reflux by 10 years. But the histologic findings, again, are what really, I think, shocked most of us who read this paper, in that 4 patients developed Barrett's esophagitis, 2 in the refluxer group and 2 in the non-refluxer group. And that is what really made us say, we need some understanding and we need some guidelines about what we should be doing. Now, what do we have to guide us? Before we actually talk about the sleeve patient, I think we need to I wanted to give a little refresher on what do we do for the general population. If we define GERD as the presence of heartburn and symptoms or evidence of esophageal mucosal injury on the scope, the average walking around down the Vegas Strip or in Omaha, Nebraska is estimated to be about 20%. The ACP has given us some guidelines on who should get an endoscopy, and it's based on either symptoms or if they have symptoms despite BID PPIs for 4 to 8 weeks, or if you do a scope and you are treating them, you should repeat the endoscopy, and then they have some other recommendations. As far as Barrett's esophagitis, the American College of Gastroenterology also has given us some guidance on what exactly is Barrett's, what the incidence is, and recommendations on biopsy techniques. SAGE's first published guidelines in 2008 on the role of endoscopy in the bariatric surgery patient, but as you can see, these guidelines from 2008 precede everything that was talking about Barrett's esophagitis developing de novo in a sleeve patient, and so there really are no recommendations in this document regarding the post-sleeve patient and what we should be doing. It really only covers endoscopy in a gastric bypass population and has to do with stenosis and bleeding and stenting for leaks. So really, right now, the guideline paper that I think we all need to become familiar with, because it really is probably what will guide us over the next few years until either a better paper with more background and research behind it comes forward, is going to be the ASMBS guideline that was just published in April of this year. It does have some documentation in the paper, if you have not read it yet, that talks about the documentation and the definition of GERD and surveillance for the non-bariatric patient, again, establishing that baseline. But as far as preoperative EGD for the sleeve patients, and that document does cover all of metabolic and bariatric surgery, not just sleeves, but for the purpose of this talk, I was asked to focus on the sleeve patient. So for the purposes of the sleeve patient, they looked at 28 studies and the role of endoscopy pre-op. And when they pooled those 28 studies, they had over 12,000 patients, and you can see the demographics. And their conclusion was about 27% of the patients had endoscopic evidence of GERD, whether they were symptomatic or asymptomatic. 35% of the patients had at least one abnormal finding on that scope, and the findings included things such as hiatal hernia, erosive esophagitis, Barrett's esophagitis, and there were in some of the studies unexpected findings of actual malignancy. Now, when you look at the asymptomatic patients, you are still likely to find hiatal hernias, erosive esophagitis, and even possibly Barrett's. So there are some people that will make the argument that you only need to do preoperative endoscopy if they have symptoms. But I think when you look at this pooled data, you will find that even asymptomatic patients, you need to seriously consider preoperative endoscopy. Now, as far as objective endoscopy and testing after the vertical sleeve, they found 11 studies where patients had both pre- and post-operative scopes to use pooled data. Now, not all of the studies looked for exactly the same set of findings, so the denominator is not the same for every one of the findings. But for example, GERD symptoms developed in 67.4% in the 4 studies that looked for it. Erosive esophagitis and hiatal hernia, only 9 of the studies looked at them preoperatively, but they both ran around 17%. In the 9 studies that we knew about whether they had them preoperatively, 25 and 11% developed de novo postoperatively. And Barrett's esophagitis in the 4 studies that looked for it did develop postoperatively. So that 10% number is pretty consistent with the 2 studies from 2017 and 2019 that kind of raised the flag that this could be an issue for us in our sleeve gastrectomy patients. So this is kind of a consistent number that keeps showing up. Now, if we take a deeper dive into those 4 studies that showed about a 10% rate, though, the ASMBS guideline paper does point out that none of those 49 patients had Barrett's on their pre-op EGD. All of them were short segment Barrett's, and none had dysplasia. But 8 of the 49 were still asymptomatic. So again, the people who will argue we only need to do follow-up endoscopies on symptomatic patients, these 8 patients will show that that is probably an incorrect thought. And until we have better data, we probably need to be thinking that Barrett's is a risk for both symptomatic and asymptomatic sleeve patients. Now, there are some limitations. These 4 studies, 2 of the 4 did not mention if they followed the ACG guidelines as far as their definition of Barrett's esophagitis. For example, they didn't mention how long the segment of salmon-colored tissue was. And 2 of the 4 did not document things such as the circumference, or was it 1 centimeter, 1.5 centimeters, etc. So at this point in time, as of the paper in April of this year, the ASMBS is recommending that all patients seeking metabolic and bariatric surgery should have a thorough GI history and review of systems. And patients with conclusive and objective evidence of preoperative GERD by testing or severe symptoms are better served with a gastric bypass than a sleeve gastrectomy. However, the effect on GERD is not the only comorbidity to drive our shared decision-making process. Postoperatively, the follow-up recommendations, we should follow the recommendations for the general population, but they do add a conditional recommendation. So until we have better data that could guide better recommendations, they recommend a sleeve gastrectomy after 3 years. It's 3 years after the sleeve gastrectomy, getting an EGD, and if that one is normal, continuing to get EGDs every 5 years. Now, there was a guidelines panel done here at SAGES on Tuesday with a multi-society consensus conference regarding the treatment of GERD. It was not in any way specific to the sleeve patients, but there were some subtopics discussed that may impact our thoughts on this issue, so I look forward to seeing that paper. Now, one of the questions, I did mention in my disclosures that I'm the chair of the Bariatric Steering Board for EPIC, and so one of the questions that I always have is, how am I supposed to remember to do this? We lose our patients to follow-up, we don't see them, and how am I supposed to remember when they're 3 years out? And I think one of the important things we all need to be having a national and international discussion about is, how do I remember to do this? And I really think we need to be leveraging our EMR. So in EPIC, I will tell you, those of you on EPIC, I hope I have good news for you. The Bariatric Steering Board is working on a health maintenance alert to help us do this, and it should be available in your foundation systems in 2022. So just like you can get alerts if someone has missed a vaccine or needs a colonoscopy, you should get one saying that they need a post-sleeve EGD and when it is due, and it'll fire when they are coming up on 3 years out from surgery, and then if you say that that one was normal, it will fire every 5 years. And if anyone has any connections with the other EMR vendors, once we've kind of developed it, we're happy to kind of talk to them and share that. So thank you very much, and I'm happy to answer any questions when we get to the panel at the end. Thank you.